Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is Bacillus Anthracis. Bacillus anthracis is a zoonosis most commonly reported in Africa and Asia. Climate and agricultural practices influence the distribution and outbreaks. The condition is rare in developed countries due to effective animal vaccination and public health measures. Human infection is usually due to inoculation, and you should be aware of its potential use in bioterrorism. Bacillus anthracis is a gram-positive, rod-shaped, spore-forming bacteria which is found in soil. It is the cause of anthrax and can also lead to malignant pustules as well as hemorrhagic pneumonia. Invasive disease is often fatal. Bacillus anthracis may enter the body through spore inhalation, ingestion, or cutaneous entry. Germination of spores into vegetative cells takes place in the host, and key virulence factors include protective antigen, lethal factor, and edema factor. These form lethal toxin and edema toxin, leading to widespread tissue damage. Clinical manifestations can take three main forms, which include cutaneous, which is the most common, inhalational, and gastrointestinal. So firstly, the cutaneous form involves a painless papule progressing to a vesicle and subsequently to a necrotic ulcer with a characteristic black eschar. Secondly, the inhalational form comprises an initial flu-like symptomology progressing to severe respiratory distress, shock, and meningitis. And thirdly, the gastrointestinal form involves abdominal pain, vomiting, severe diarrhea, and hemorrhagic gastroenteritis. The management of anthrax requires early antibiotic therapy, which is crucial. Usually this is with penicillin, but you can also give doxycycline and ciprofloxacin. Antitoxin may be required for systemic involvement. Immunisation needs an annual booster, and therefore this is really only given in high-risk populations. Preventative measures include animal vaccination, control of outbreaks among livestock, and proper handling of animal products. And as we said before, you should be aware of its potential use in bioterrorism as well. So let's try our question. A 45-year-old male farmer presents to the emergency department with a 2-day history of fever, a painful swollen area on his forearm, and a black eschar surrounding the edematous skin. He reports handling sick livestock without protective gloves a week ago. Which of the following is the most appropriate initial management for this patient? So our options are immediate initiation of IV penicillin, surgical debridement of the eschar, administration of tetanus booster, oral clarithromycin, or application of topical steroids to the lesion. And you will recall from what we previously discussed that in these patients, urgent antibiotics is crucial, and usually this is penicillin. Clarithromycin would not be effective for anthrax. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.